Well, good morning, good afternoon, good evening, depending on where you are. My name is David Lewinsohn. I am a TB immunologist based at Oregon Health and Science University in Portland, Oregon, and I represent all of the new tools groups for the Stop TB partnership. I'm very pleased to be able to kick off today's seminar or some tech symposium called Ending TB, Right Dose and Right Time. And I think we all know that TB is a treatable disease. And in fact, it's been treatable for more than 50 years. But in spite of that, we live in a time of paradox when TB remains a leading cause of infectious disease. And really, its eradication will depend on finding those with TB, treating them efficiently and rapidly, and ultimately the development of vaccines. I'm very pleased today to have a really distinguished panel that we'll be able to introduce today. Those include Sergio Carmona, the Chief Medical Officer of FIND, Maria Beumont, the Chief Medical Officer of the TB Alliance, Lou Schrager, who's the Senior Leader of TB Impact Area IAVI, Tina Shah, who's an MDR survivor, and Francesca Conradie, who is at the University of Witwatersrand, as well as Robert Matiro. So just a couple of notes for the session. I'll be introducing each of the speakers as they go forward. And the order will actually be Robert Matiro, Tina Shah, Sergio Carmona, Maria Beumont, Lou Schrager, and Francesca Conradie. And then we will have Willow Brock filling in as a panelist towards the end. We will have about 40 minutes for a panel discussion with each presenter having 7 minutes for their panel. And then we'll have about a 40-minute time for discussion at the end. So with that, I'm going to be pleased to introduce our first speaker, who's Robert Matiro. He is the Director of Operations at Unitaid and has spent the last 22 years working in global public health on a variety of initiatives to which he has brought experience and expertise in multi-sectoral program management. And with that, I'm going to go ahead and turn this over to Robert. Robert, go ahead.
Thank you very much, David, and a big thank you to FIND, IAVI, and the TB Alliance for inviting me to join the other panelists and speakers for this really important webinar. If you can just go to the first slide of my presentation and then click again. So my presentation is to really just remind us why it is so critical at this juncture in the global response to TB to invest in new tools to help drive us towards the 2025 and 2030 targets. What you see in this slide are the targets that have been set by the global constellation of partners and captured in the Global Plan to Stop TB for 2025 and 2030 respectively. What you'll see on the far right of the slide is that we still have a significant way to go when it comes to case finding and testing targets, when it comes to treatment targets, when it comes to reduction of morbidity and mortality from TB. If you click to the next slide. The public health need remains staggering. 3 million with TB remain undetected each year. 50% of the pulmonary TB cases have bacteriological confirmation. And we know full well that in the last 2 years, COVID has had a massively disrupting and devastating effect on health programs worldwide. But TB has been disproportionately affected in terms of efforts. The disruptions and delays to crucial services have caused death from TB to increase for the first time in over a decade. COVID is not the only culprit here, but in general, it has exacerbated a already difficult situation and some important progress that has started to be made, particularly in the last decade. If you look on the right of this slide, the achievement of the global TB targets is threatened. We need to get to a 20% in reduction in incidence rate, and we're at 45%. We need to get to a 35% reduction in the number of deaths. It's still pretty high. We are still not where we need to be at all in terms of reducing catastrophic costs to people's livelihoods to 0%. We have a long way to get to the total number of people we need on TB treatment. Similarly for preventive therapy, which is such a crucial intervention to prevent people progressing to disease in the first place. And in terms of absolute financing required, we're billions of dollars away from where we need to be. If you click to the next slide. This is just a spotlight on the devastating impact COVID-19 has had on TB services. And you can see here the number of people treated for TB dropped by 1.4 million, as you can see in the middle bar, alongside HIV and malaria on either side of that. It's really key that in this rapidly changing world, and to confront new challenges moving forward, updated tools and strategies are more salient than ever. The TB bacteria, I don't need to tell anybody in this room, was identified over 140 years ago, and it still causes this many deaths per year. And the pandemic has put the lack of progress relative to other disease areas and epidemics into stark contrast. For COVID, which started 2 years ago, as we know, we've developed and deployed rapid at-home tests, several powerful vaccines, multiple treatments that can avert disease, and mobilize billions in financing. And there's still much to do, but we're hopeful that will turn us around the corner. And yet in the context of TB here, we are still today facing these challenges. If you click to the next slide. I've just excerpted a slide from the Global Fund's recently published investment case for its next replenishment cycle, just to put into context for the Global Fund only, and there's several other investments required beyond what the Global Fund needs. They've identified a gap of $28 billion, of which they're requesting 18 billion for the countries that are eligible for Global Fund support, and that cuts across HIV, TB, and malaria. But it just puts into stark context what is ultimately required. But if you stack that up against what has been projected for this pandemic and before, the ask ultimately is reasonable, even though it runs into the billions for the types of targets we're seeking to reach in the next few years, and then up to 2030. Next slide. This is again a spotlight from the Global Fund investment case on just how impactful even such an investment through the fund could have in terms of the number of deaths from TB, including those who are HIV positive, through the investment case of the Global Fund. Obviously, layered on top of that would need to be other important investments that I'll come to later in terms of research and development and so on. But this just gives an example of what is really critical when we talk about investing in new tools and new approaches, that we effectively cost them and demonstrate the critical impact they'll have. Next slide. This is coming from the current global plan to stop TB, which runs through this year, and the new one is going to be published soon. But this again reminds us of what is important in terms of new investments for R&D, for new tools, medicines, 6.8 billion, just around $1 billion for diagnostics, vaccines, 3 billion, and basic science and research, 2 billion, for a total of $12 billion. And an annual funding need of 2.5 billion. The projections to come for the next plan cycle will demonstrate this level, if not more, of funding that's required. And even for this cycle, we were not able to make a significant dent in the R&D needs compared to, say, what has been put into other pandemics and epidemics, including COVID. So it's just a reminder that even in the R&D space, despite some progress, we're lagging behind in terms of investment in R&D, and we cannot expect to have new groundbreaking tools unless we fill the pipeline. And the ask again may seem large, but in terms of the multiple billions that would be saved in terms of deaths averted, lives and livelihood, again, in the same way we've made the case for COVID, it is not a significant investment at the end of the day. Next slide. Before I go into this, it's a reminder that it's not all doom and gloom. Breakthroughs in TB in the last 10 years have pushed forward significant progress. So when we put our minds and science and dollars behind it, we can actually make progress. And in the last decade, we've seen 3 new drugs, the first in half a century, and the first ever child-friendly formulations for TB, make treatment shorter and more effective and less toxic. And with quicker and more accurate diagnostic tools as well, and improved preventive therapies, we're starting to see some important progress. So there are some important foundations here to build on. We just have to up the level, a step change to advance the investment in new tools and the type of progress we can make if we can garner enough support and science behind it. In this schematic, you can see the end-to-end approach we're talking about. So investment in new tools needs to be about new tests, accelerating tools to drive TB detection, accelerating tools that can be more decentralized and integrated into systems. When it comes to prevention, we now have a very effective TB therapy, but it has to be scaled in terms of rifapentine-based treatment therapies, but also further research into vaccines, R&D. You've seen the level of effort and investment that's being put into COVID mRNA vaccines in particular, including investments for local production and capacity in sub-Saharan Africa. You've heard it before, there should not be a barrier to doing the same for TB, a disease that's been with us for over a century and a half, if we can get the right political will and financing behind it. Long-acting formulations, we have a number in development in the pipeline. Unitaid, my agency, is already investing in clinical, preclinical trials for preventive therapy for long-acting, in addition to obviously HIV and malaria. When it comes to treatment, we know we can still do better in terms of shortening regimens and making them less toxic and with having fewer side effects, and also further investments in treatments for children, particularly for MDR-TB. Adherence is really key. Many partners, including partners in the room today, are investing in different adherence technologies to support completion of treatments with these longer regimens until we can get to shorter regimens. But even then, having state-of-the-art adherence support and care for those living with the disease and needing treatment will be absolutely important. And then on the cross-cutting side, it's important to talk about investing in new tools, but not to forget the other critical enablers of access to those tools, such as eliminating IP barriers. For example, the work we do with MPP and other support to governments to help with that, where there are IP considerations. Quality, any new tools must meet the standard of quality so that those who need the care are getting the best treatments or tests or preventives available. And then obviously local production to find ways in which we can build out local capacities for more sustainable approaches, particularly when you're not talking about complex molecules. There's no reason why we can't see to take an approach that can also support countries with that. Next slide. This is my last slide, and it's just a spotlight from Unitaid, my agency, of the criticality of new tools in accelerating access and positioning them for scale. This model that you see on the left is one that we developed with the Global Fund, and it was a pre-COVID model that basically accurately showed that there could be a 3-year acceleration in access to game-changing diagnostics and treatments through innovation. With 100 million people reached with those benefits. So innovation can be a very powerful tool in ensuring that we can avert deaths and we can reduce morbidity much more rapidly and achieve targets much more quickly. Direct key drivers that are key to consider here are focusing on prevention, we think, moving forward, simplification of diagnostics and treatment, reducing through these approaches pressures on healthcare systems that are already severely burdened, integration of services with care, affordability, obviously, of global health goals and community-based care. Let me conclude by saying that as a collective, our investments in TB have helped us respond to COVID-19. When the first cases emerged, our TB experts were called in as the first line of defense. We leveraged molecular platforms that have been in place for TB and HIV. As we think about investing in new tools for the TB response and shoring them up, it's important to articulate in our investment cases as we seek funding from different sources for this, that these investments will not only drive the response to TB, but if done smartly in an integrated way, can also be the backbone of vital global health responses in the future. For future epidemics and pandemics as well. So let's not look at this as a vertical response, even though we must address it for TB, but one that will position us better to strengthen systems more holistically. Thank you.
Thank you, Robert, for that. Sorry, go ahead, David.
Yep, sorry, I didn't realize I was muted. So we have next up, we actually have Tina Shah, who's going to be talking about investing in new TB diagnostics, such as LAM, POC-MD-TX, POC-MDX, etc. And Tina is a pharmacist and TB survivor, part of We Are TB, and is a mother living of two living in Virginia, who was diagnosed for TB in 2002, 2003, when she was a senior in high school. So go ahead, Tina.
Thanks, David. As David mentioned, my name is Tina Shah. I'm an MDR TB survivor and a member of We Are TB, as well as a member of the TB Trials Consortium Community Research Advisors. The Tuberculosis Trials Consortium, the TBTC, is a unique collaboration of researchers and community advisors whose mission is to conduct programmatically relevant research concerning the diagnosis, clinical management, and prevention of tuberculosis infection and disease. We Are TB is a growing survivor network that is fighting to achieve change in TB diagnostics, treatment regimens, and funding to support US and global public health programs. I wanted to start with sharing my personal experience with TB because I think that it's really important to share these stories to understand how the disease really affects the individuals. So my personal experience with TB started in 2002 when I was 18 years old and I started coughing up blood. My family rushed me to the local ER, and since TB was not even on the radar of diagnosis, especially here in the United States, a chest x-ray was not even done, and I was told that I had an esophageal tear, and I was sent home and told it would get better. Fast forward a few weeks, and I remember sitting at my high school graduation, a moment that's supposed to be a milestone, worrying about holding in a cough. A few days after graduation, I could no longer climb the stairs of my home, and I was again rushed to the ER. This time, upon chest x-ray, it was determined that I likely had TB. I spent 10 days in isolation at the local hospital, during which my high school and close contacts were contact traced. It was a horrifying experience for an 18-year-old, and I quickly discovered the stigmas related to infectious diseases like TB. The majority of people were unfamiliar with TB and didn't understand the disease. I soon after began treatment with the local health department in Montgomery County, Maryland. We started with the usual 4-drug regimen: isoniazid, rifampin, ethambutol, and pyrazidamide, and cultures were sent to make sure these drugs would work. We tried to figure out where I'd gotten TB from and traced it back to a likely exposure as a child at age 5 or 6 while visiting family in India. Likely my exposure was from an older family member that took drugs on and off for TB due to cost, and eventually, due to drug resistance, died of TB. Unfortunately, during a childhood screen, I remember having a positive skin test for tuberculosis, and my family was told not to worry about it since I had been born in the United States. A few weeks after starting the 4-drug regimen, we learned that my TB strain was resistant to isoniazid, streptomycin, an older TB drug, and partially resistant to rifampin. I was told I had multi-drug resistant TB and it would be harder to treat. The health department had little experience with drug-resistant TB, so they contacted the CDC, Centers for Disease Control in the United States, for guidance on next steps. In 2002, the drugs available for TB were only the very old ones that had been used for years. Unfortunately, there was no clear regimen for how to treat me. We had to go through a little trial and error to figure out a treatment course, and I was told that likely I would have to do 9 to 12 months of treatment. As fate would have it, I was slated to start at Georgia Tech in Atlanta, Georgia that fall. A doctor from the Centers for Disease Control headquarters in Atlanta, who serviced the local health department for some TB cases, took on my case. I remember being relieved and grateful for her patience and expertise. I experienced directly observed therapy and met in person with a health department nurse 5 out of 7 days a week. As an 18-year-old, it was very burdensome and difficult to get through the treatment course. The treatment side effects did not come without their challenges. My entire treatment took 1 year. 1 year of over 10 pills a day. Even with all that, I know that I likely got the best treatment and care available in the world at the time. Likely, if I had been in another country, I would not have been a survivor. 2022 marks 20 years from my diagnosis and start of treatment of tuberculosis. While I'm grateful to be a survivor, I'm disappointed that 20 years later, we have not eradicated this disease. As our speakers today will tell you, some progress has been made these past 20 years with diagnostics, shorter treatment regimens, newer drugs, and the possibility of vaccines, but that progress is underfunded and not moving at a pace that will eliminate tuberculosis anytime soon. So as you'll see with the rest of the speakers in today's event, you'll see insight on the need for increased investment in these research and development of diagnostics, treatments, shorter regimens, and vaccines to continue making the progress toward the goal of eliminating TB in the United States and abroad. I hope my TB story helps shed light on the importance of this funding and research and conveys my hope that we make faster progress on eradicating TB. And with that, I will let some of these other experts go ahead and share their knowledge and expertise on the TB area.
Tina, thank you. And thank you for being so patient. I think I misattributed your talk with that of our next speaker, which is Sergio Carmona. Tina really gave us, she really gave us the community perspective and that of a survivor. And our next speaker is actually Sergio Carmona, who will be in fact talking about investing in new TB diagnostics such as LAM, point of care MDX, and next generation sequencing. Sergio is the Chief Medical Officer of FIND, and he joined there in 2019 and has had experience in a variety of other diseases, most recently COVID-19, HCV, and TB. So with that, Sergio, the floor is yours.
Thanks, David. I was a little surprised, but Tina set the scene really well for me in that, yes, I'm really sorry about your story, but glad that you have a strong voice and continue to advocate for both early diagnosis, access to diagnosis, and the tools that we need to combat TB and MDR-TB. So David, let me start by briefing everyone. Next slide, please, sorry. For those who may or not know, FIND is the Foundation for Innovation in New Diagnostics, the Global Alliance for Diagnostics, and our new strategy is, at a glance, is shown here with a clear vision to drive equitable access to reliable diagnostics through a collective action. And the impact is that we foresee is at least of 1 million lives saved and working at least to empower 10 countries. Our goals are in two main areas around universal health coverage and health emergencies. And the universal health coverage, we aim to expand our primary care testing to target key diseases, not only TB, but malaria, fevers, or fevers of unknown origin, hepatitis, some of the non-communicable diseases, and continue our work in neglected tropical diseases. And the health emergencies, we've been working prior to COVID on antimicrobial resistance and other epidemics and pandemics, and more recently on COVID. How we work, and maybe my next slide will be a bit clearer in two areas, and this ties up well with what Robert alluded to in his model with the Global Fund. Innovation is key, and both in technology and also innovation in making diagnostics accessible. So here we partner with users and buyers. Maybe can we move to the next slide? I think, great, thank you. So we partner here with, so we want to enhance our network and our partners and community of partners. Here we aim, sorry, let me check where we are. We partner with users and buyers to co-create fit for purpose diagnostics tools, as well as to ensure that these ultimately lead to policy change and procurement or demand. So we've been working on developing transformational diagnostic tools, as you alluded, David, on LAM, generate evidence that supports guidance and implementation, build on local production. And I think this was made clear through COVID that depending on very highly centralized areas of diagnostic production, can lead some regions without supplies, as well as to develop and ensure that there's a healthy market, both in terms of access to diverse tools and interventions that make these tools at a price that is suitable for the countries where we work in. And on the access innovation, so one without the other would not lead to what we need to achieve to provide tools for the elimination of TB within the target periods set by WHO. Here we're designing new delivery models, including self-testing and digitalization of diagnostics, especially more recently with COVID. Support countries to embed this testing and evidence within the surveillance systems that they have, and strengthening diagnostic capacity. And this means from communities as well as district level hospitals. Next slide, please. So from a technology perspective, pre-pandemics, 2 years ago, we had only a few types of diagnostic tests that could address pandemic pathogens. And these tests were not necessarily available at community levels. We work, and as we know now, these communities are key to containing any outbreaks or hotspots. And never before have we seen how diagnostics have become part of not just the health system, but our education and economy overall. So please, next slide. So it's no, okay, sorry. So like vaccines, the pace of innovation in diagnostic tests developed in the last 24 months has been remarkable and really unprecedented. If I think of malaria or HIV, as many of you are very familiar, from development of new tools, a rapid RDT for HIV to where it became available, it took about 10 years with evidence and guidance and many generations of new diagnostics. With COVID, this is basically being shrunk to just a couple of months, to 12 months or so, 24 months. So it's taking on that pace. We want to see how some of these innovations can leverage what is required for TB. Next slide, please. So it's no exaggeration to say that COVID has really, really accelerated. And some are calling it the third revolution of diagnostic technologies, not just for pandemics. So I'll spare you all the details on what this means, but in essence, different methodologies, not just classic PCR, nucleic acid amplification, has been developed or become accessible to commercially available kits or diagnostic tools. These new technologies are in new formats, so something that used to be quite large and mainly accessible at very centralized laboratories. Now it's been miniaturized and available at point of care and near primary healthcare centers, as well as the complexity of what it used to take to treat a specimen or sample from a patient to be tested has also become much simpler and faster. So compared to the last 2 years, there are now about 56 novel new patient molecular diagnostic tools that we are busy looking at and see how these can be effectively implemented in priority countries where TB burden is high. So next slide, please. So new diagnostic tools are needed to recover from this pandemic. As Tina said, stigma to infectious diseases, in particular TB or HIV, have been there before the pandemic. But because of symptomatology similar to TB, we saw in the last 2 years the effect that COVID had on those who were infected with TB. So there was reluctance of patients or clients that were infected with TB to access health facilities, as well as because of the pressure and demand on the health system because of COVID. This also resulted in either delays in diagnosis of TB or a complete lack of access because of the burden that the pandemic had on other services. So clearly we need a new approach. We need new tools and innovation to recover from what this pandemic have put on us. Next slide. So together with other partners, including Unitaid, we are investing and looking at 3 classes of game-changing technologies. The first one is the 3rd generation of LAM. The second one is point of care, thank you, a real point of care molecular diagnostic tool fit for TB using non-sputum sample. And the third is a healthier market on new or near point of care molecular diagnostic tools. You may be familiar with the Gene Expert. There are many up and coming technologies that fit into the space as well. So here's about optimizing an easier to use sample type like urine, for example, for TB LAM, using also point of care molecular diagnostics that have been accelerated in development and scale through COVID and new technologies on point of care. Next slide, please. So here is a really exciting development from about 2019. FIND was awarded a multi-year grant by Unitaid, and this was really targeted sequencing for those a bit like Tina that were affected by drug-resistant TB. And maybe those who are familiar with the HIV ResNet, it's similar to that, to develop evidence to boost country capacity to support global adoption of next generation sequencing that is targeted to identify DR mutations. Here, together with WHO, a catalog is being put together, which we hope will be made public at the end. That has been, it's nearly there. That is associated in multiple mutations in various settings. This aims to project to do 2 things. One is to look at the technologies that are available for next generation sequences in the context of TB and ensure that these are simplified and easier to use, since there isn't such a thing for TB, and to generate this catalog of evidence of how each of these mutations ultimately result in a phenotypic change, and for the clinician at hand to help them guide what new drugs to use. So next slide, please. So here you can see that there are 4 main outputs to involve the development of this clinical or knowledge base that will be managed through by WHO, which will be a library, if you want, of mutations and the clinical consequences that these will have, and also to generate evidence of how to make these new tools implementable. So we're really excited about the opportunity through this grant to develop this really game-changing platform. So that's it. Thank you, David. Over to you.
Sergio, thank you very much. That was really fantastic. So I think our next speaker is Maria Beumont. She is the Vice President and Chief Medical Officer of the TB Alliance and has been developing and leading the clinical strategy to provide oversight of clinical trial planning and execution of promising anti-TB drugs and regimens. And her title is Investing in Shorter Regimens for Drug-Resistant TB, including BPAL, TB research needs, 4-month drug-sensitive regimen, and shortfalls in funding. Maria, go ahead.
Thank you, David. Thank you very much. And good morning, good afternoon, good evening to everybody. I'd like to start by saying that I'm very happy to participate to this webinar today, because I think the topics we're covering are critical and very important. And so I'm very excited to be part of the conversation for that reason. But I'd also like to say that I was very touched by Tina's story. I think that she reminds us very eloquently why we're all here today. And it's incredible to hear that her diagnosis was made 20 years ago, and that we unfortunately continue to have some of the same discussions today. So I'll start my presentation reminding us that TB Alliance is a nonprofit organization that dedicates to the discovery, development, and delivery of fast-acting, robust, but also affordable treatments for tuberculosis so that all patients in the world can access them. We're managing a large pipeline of TB candidates And our objective is to identify and advance those candidates that hold the highest promise in terms of further simplifying and further shortening treatment duration, because we think that this is the way in which we are going to have the highest impact in the fight against the tuberculosis pandemic. Next slide, please. An example of how we see our mission is the BPAL regimen, which is summarized in this slide to the right in blue. The BPAL regimen is composed of 3 different compounds that are administered orally, all of them, for a total treatment duration of 6 months, and with very high efficacy, cure rates of 90%. And this, importantly, considering that relates to patients that are very, very hard to cure, patients that are infected with extensive resistant tuberculosis. The BPAL regimen was approved for use in 2019 in the US, and this is after the compelling results from the next TB trial were made available. At that point in time, then patients with extensive resistant tuberculosis were offered a therapeutic alternative that was much more attractive to the one that Tina had to take 20 years ago, which is the old treatment standard, characterized by a very high pill burden, sometimes including injectables, very long treatment duration. For Tina was 1 year, but sometimes can be up to 2 years and even longer, with poor tolerability that gets in the way of adherence. And I know I'm not saying anything new here, and also poor efficacy of 30 to 50%. So BPAL represents a breakthrough in treatment of extensive resistant tuberculosis. I'd like to stress the point that BPAL was developed with funds from national governments and foundations, and also throughout very strong collaborations with researchers all around the world. And I think we're very lucky to have Dr. Francesca Conradie joining us at this webinar today, because she's been one of our key collaborators in this journey. She was the principal investigator for the TB, for the next TB study, and also continued to accompany us in all of the different stages of development of BPAL that are still ongoing. But while we celebrate the successes of BPAL, we are cognizant that there's still lots to be done. And for this, we realize we need to partner with regulators, with healthcare infrastructures, and also continue to work with researchers around the world. There's no lack of passion and there's no lack of scientific attention to tuberculosis, as we all know, but these two need to meet the adequate funding in order for us to be able to make reality all of our aspirational objectives. Next slide, please. This is a very nice picture that depicts the striking difference in pill burden that I was just talking about for the BPAL regimen compared to the old standard treatment. And this very significant difference in pills, so the BPAL, of course, here is shown towards the left in the picture, is much more significant when we consider the higher efficacy and the much shorter treatment duration of the BPAL regimen. And so we can very, very easily appreciate the difference that BPAL makes in the daily lives of patients that require treatment for extensive drug-resistant tuberculosis. Next slide, please. So we do focus on improving therapeutic alternatives for patients with tuberculosis, but we're also very committed to access and making sure that these innovations make it to the patients that need it the most. For us, like for other product development partnerships like FIND and IAVI, it's very important that we establish very good partnerships with strong healthcare infrastructures in order to be able to facilitate the adoption of these innovations. And an example of when things don't work properly is just the current situation in Ukraine today. So Ukraine, which is a high-burden multi-drug resistant tuberculosis country, has been the one that drove the uptake of operational research for BPAL, and did so very successfully, reporting rates of cure of around 90%, very comparable to the rates that have been reported in the clinical trials. So successful that our local partners in Ukraine were getting ready to upscale operational research in Ukraine to the national level. Unfortunately, this occurred right before the invasion in Ukraine, and so this project now has stopped, and its future is very uncertain. And this is a real shame, particularly when we consider that this is a country that has high burden multi-drug resistance tuberculosis. So the consequences of this, of course, are terrible and very long to list right now. Next slide, please. I'd like to now close my presentation with a more optimistic note, and that is to share with you our long-term vision of the future of tuberculosis treatment. We know that clinical data has suggested or suggests that a total treatment duration of 4 months seems to be sufficient for most patients who are infected with tuberculosis. And we also know from the BPAL regimen that 6 months seems to be enough for patients with extensive drug-resistant tuberculosis. So these are the two treatment duration benchmarks that we're working with right now. But these are benchmarks that we'd like to improve upon. We think that total treatment duration is very important, and the shorter the treatment, the better it will be, because it will have a direct impact on adherence to treatment. And adherence will have a direct effect on the outcome of treatment for the individual patients taking therapy, but also indirectly will have an impact on transmissibility of disease and also emergence of resistance. So we're working towards shortening treatments beyond what's known today. And we dream down the line of a day in which patients will be treated in a matter of days or in a matter of weeks at most. Of course, this is our aspirational goal, and lots of things need to happen between now and then. We need to partner with regulators and with healthcare systems that will embrace this innovation when they become available. And the risk of sounding redundant, of course, funding is going to be very critical in order for us to be able to achieve these aspirational goals. I'd like to close with the fact that I think that while we all know and understand the detrimental effects of the COVID pandemic on tuberculosis, as some of the previous speakers already mentioned, I think we need to recognize the incredible results of the combination of focused science and adequate funding against the fight towards the COVID pandemic that led to the availability of solutions for the COVID pandemic in record time. And we celebrate these achievements towards the COVID pandemic, but we now hope that the tuberculosis pandemic will achieve the same kind of attention in order for us to continue to fight and improve over what's been done, because tuberculosis continues to kill patients daily all around the world. And this is after the many, many years since it's been discovered, as already mentioned by someone else today. Thank you very much for listening. I will answer any questions now or during the QA session, whatever David thinks is best.
Is to kind of save our questions, I think, for the panel discussion, as I think we'll have quite a bit of time there. So with that, I'd like to turn this now over to Lou Schrager. Lou is the Chief Medical Officer at IAVI. He is the senior leader at IAVI for the TB impact area. And this now includes HIV, TB, and emerging diseases, including COVID-19. And Lou's talk is actually on accelerating vaccine research to end TB. So Lou, go ahead.
Thank you, David. And I'd like to thank the organizers, Fund TB Alliance, for inviting me to participate in this webinar this morning. Next slide, please. I'd like to thank the funders and partners at IAVI that make our work possible. Next slide, please. So what I'm quickly going to do this morning is to discuss the need for a TB vaccine, the progress we've been making in the area, as well as the challenges that we face. Next slide, please. So delivering a new vaccine for tuberculosis is truly a global health imperative. TB has caused more deaths globally than any other single infection over the past decade. Until COVID hit, it was the leading infectious cause of death yearly since, at least since 2010, probably earlier than that. A new TB vaccine is required to reach the WHO End TB strategy targets of 95% reduction in TB mortality and a 90% reduction in TB incidence by 2035, as you can see by this graph at the right with the diverging line at on the bottom, demonstrating the need for new vaccines as well as other tools to reach that target of only 10% incidence rate per 100,000 per year by 2035. And additionally, vaccines offer the best chance to contain the accelerating spread of MDR TB, mainly by reducing the need for new drugs by reducing the incidence of TB disease. Next slide, please. So when we talk about developing a vaccine for TB, you have to conceptualize this really in two ways. What are you really developing your vaccine for, and in whom? So your target indications for vaccine development writ large are preventing infection with MTB, preventing actual tuberculosis disease, and then preventing people who have been successfully treated for active TB for recurrent disease, prevention of TB recurrence. And your target populations are infants, adolescents, and TB patients, respectively. Modeling has shown, however, that while all three of these, the target indications are important for public health, the real money, the key effect of reducing the TB pandemic would occur if we could prevent active pulmonary TB disease in adolescents and adults. Next slide, please. So as I'm sure everyone on this in this webinar knows, that we do have a vaccine against TB. It's called BCG. It's the only licensed vaccine against TB. It's derived from Mycobacterium bovis. After a lot of work that was done in the Pasteur Institute in Lille by Calmette and Guerin many years ago, more than just over 100 years ago, 230 passages of M. bovis resulting in this vaccine construct, given at or close to birth in infants across the world in endemic areas for TB. There have been more than 3 billion doses of this vaccine given, making it the most frequently administered vaccine in the world. And it does have efficacy in preventing severe TB disease in infants, mainly meningitis and the miliary spread of TB. It has a variable degree of protection against preventing primary MTB infection in children. And however, it provides an unreliable degree of protection against the development of pulmonary tuberculosis in adults resulting from the initial newborn vaccination. Next slide, please. So as evidence of the insufficiency of BCG alone in preventing the TB epidemic, you have to look at the epidemiology of TB. Despite the near universal vaccination of infants with BCG in TB endemic countries, we still have approximately 25% of the global population infected with MTB, somewhere around 1.8 billion people. 10 million people developed active TB, and 1.5 million died of TB in 2020. And, there's evidence that infant BCG offers little or no protection against transmission. So that because infants and younger children are not a significant source of transmission, and that the initial infant vaccination with BCG, the protection that would be manifest wanes to or near zero 10 to 15 years after vaccination, right at the time when MTB transmission increases. Next slide, please. However, now 100 years or so after the first use of BCG, we're seeing important new progress in the field of TB vaccine development. In 2018, results were published from a study in which one arm of which included a BCG revaccination arm in adults, in adolescents actually, resulting in a 45% reduction in sustained interferon gamma release assay conversion compared to placebo in MTB uninfected adolescents. Just a year later, a study was published demonstrating that a conjugated protein that was adjuvanted in M72-AS01E vaccine in a phase 2b study for protecting against TB disease in adults who were HIV negative but IGRA positive resulted in 50% protection against the development of TB disease. Next slide, please. So this is the current global pipeline of TB vaccines in clinical trials. I don't have time to go through all of these in detail, but there's a couple of general messages here. One, some good news and some challenges. The good news is that 5 years ago, if I were to show you this slide, most of these candidates would have been in the phase 1, phase 2A side of the pipeline. You can see that many now have moved to phase 2B, phase 3 late stage trials. So we're going to get some efficacy data in the next few years. This is very encouraging. I'm highlighting 3, the VPM-1002, MTB-VAC, and M72-AS01E as the ones that both are at or approaching phase 3 efficacy trials, and that with the theme of this webinar this morning could really benefit in terms of accelerating assessment from increased funding. So that's some of the good news. Another piece of good news is that there's a reasonable diversity of vaccine strategies here, from viral vectored vaccines, adjuvanted protein, live attenuated vaccines, etc. The not so good news is that the upstream part of the pipeline, phase 1, you can see that there's kind of a dearth of candidates coming in. Normally you'd see a different pattern to a pipeline. I think Mark Hatherell in the most recent Global Forum described it as an inverted pipeline. And that is because there really hasn't been the kind of research and development in basic TB immunology and vaccine development to continue to provide new constructs for assessment in clinical trials. Next slide, please. So we're facing important challenges to developing successful TB vaccines. Perhaps the most important of which is we don't have a correlate of immune protection. That is, we really don't know what an effective immune response looks like against TB. We don't have a target for a vaccine, the kind of immunological target that would be very helpful as we try to develop these vaccines. We have a sense of what might work, but we don't have proof of an immune response that actually protects against TB. There's a lack of an animal challenge model that reliably predicts vaccine efficacy in humans. And critically, there's a lack of sufficient funds to develop and test new TB vaccines. Next slide, please. So my concluding slide is an illustration of the disproportionate underfunding of tuberculosis vaccine research and development relative to the public health impact, in this case measured by mortality, as compared to other important global health issues such as HIV, Ebola, and COVID. So on the left side of the graph, you can see these different diseases. You can see the number of deaths, in most cases in 2019, with TB 1.4 million, HIV 680,000, Ebola, the whole outbreak up to 2020, approximately 14,000, and the COVID, relative to the amount of vaccine-related R&D. And you can see the disproportionate lack of funding for TB vaccines as compared to these other diseases, which is an important theme, I think, for the webinar. So just in conclusion, it's this kind of funding, not only for TB vaccines, but for diagnostics and therapeutics, that gets to what Tina, I think, so eloquently called for in her very moving presentation. And that is a global effort to eradicate this truly eradicable disease through the combination of the development of new diagnostics, drugs, and vaccines. So thank you very much.
Lou, thank you so much. That was fantastic. And we have our final speaker is actually Francesca Conradie from, she's the Deputy Director of the VITS Healthcare Consortium and Principal Investigator of NICS-TB and ZNICS clinical trials. I don't have a title, but I presume it's going to be about how she helped coordinate those specific trials. So Francesca, the floor is yours.
Thank you very much. Just a couple of things. The name of my university, somewhat complicated, is called the University of Witwatersrand. And I work for VITS Health Consortium. My talk, and I'm not going to be showing any slides, but my talk is on the country perspective on the need to invest in new technologies to end TB. I work in South Africa. I'm a South African trained and born clinician. And in terms of my career, I started off working in HIV research in about the year 2000. And in about 2009, I transferred my research agenda to that of tuberculosis, and in particular, the treatment of drug-resistant TB. There were many parallels at the time. The treatment of HIV went from being quite toxic to easily tolerable, and many parallels have occurred between that and the treatment of drug-resistant TB. But as many speakers have said, tuberculosis diagnosis, prevention, and treatment has been treated for centuries as the poor cousin of the poor cousin. The fact that drug-sensitive TB is treated the same way as it was when I qualified over 30 years ago is really a testament to how little R&D has been done, particularly in the drug-sensitive realm. The good news is that in drug-resistant TB, there have been far more strides ahead. I think particularly because the treatment was so awful, we had great difficulty in assisting patients in completing their treatment. So what have we learned in South Africa about investing in new technologies to end TB? I think the first one, and probably the most difficult one, is the fact that you require political commitment. In South Africa, until very recently, the MDR Directorate, Dr. Norbert Njeka, spearheaded the gains that we have made within our drug-resistant TB program. He has now been been appointed as the chief officer for TB overall. So hopefully the innovation that he has brought to drug-resistant TB will move over to drug-sensitive TB. In terms of what it takes to actually implement new technologies, I want to cover some of the practical aspects of it. The first thing is that, and when I'm talking about technologies, I'm talking from diagnosis, treatment, and prevention, is the first thing that we need to do as an individual country is that the country needs to take the WHO guidelines and decide what's applicable and affordable to that particular country. And for example, in South Africa, at least 50% of our patients who have TB, both drug sensitive and drug resistant, are HIV co-infected. And if the guidelines do not cater for that population group, difficulty in diagnosis and interactions with antiretroviral therapy, the bottom line is it's not pretty useful to South Africans. So we need to translate the guideline developments into our own local guidelines. And I don't want to belabor the point too much of this analogy, but then the next thing that has to occur is training. And the TB program is often like the Titanic. It doesn't turn very quickly. And I'm not going to continue the analogy to what happened to the Titanic in the end. So the training needs to go from community awareness of new drugs, new diagnostics, the importance of TB, the signs and symptoms of TB, to nurses who are working in the clinic to make sure that they're screening as many patients as possible and finding the diagnosis. Then the training to the doctors to make sure that that they are aware of the new treatments and the new potential side effects and what to look out for. And that, believe me, is a really difficult task to undertake. To change people who've done this, to change people's minds who've done the same thing the same way for the last 20 odd years, it's a big ask. In addition to that, in South Africa, we diagnose about 200,000 cases, 200 to 250,000, depending on where we are in the COVID epidemic, cases of TB. 2 to 3% of them are rifampicin resistant, and scarily about 50 to 100 of them are bedaquiline resistant. So what we need to do is, if we're going to implement something, we have to have an adequate supply chain. If we're going to use a new diagnostic, where will it be conducted? Who will do it? Who will do the QA? Where will the reagents come from? Does it need uninterruptible power supply? If we're changing drugs for the treatment of drug-resistant TB, the same thing applies. We have drug tenders, like all countries, for the for what's going to be commonly used for the treatment of TB. And if we're going to change, we've got to take into account what that change will take and to get adequate supplies so that everyone who lives within our borders can access these new particular regimens. So introducing new technologies into TB, there are multiple layers that we need to consider, not only just the fact that we've got a new vaccine or a new diagnostic, but how we're going to implement it in a way that affects the people who are living within our borders they get the most benefit from it. I want to just, before I talk about our track record in South Africa, because we do have a really impressive track record of introducing new technologies, I want to just bring a reality check to the vast majority of people who are diagnosed with TB in the world. They generally live in poorer communities. They live in communities where there is not much ability to be resilient. There is not huge amounts of savings that can help offset the catastrophic costs of TB. If I tell a patient that they've got extensively drug-resistant TB and their answer is, that's not my biggest problem in my life, the truth is they've got huge problems that need to be overcome. And we need to, even with the best drugs in the world, and as mentioned, I was the principal investigator for Xenix, even with a 90% cure rate, we have to be very careful that we pay attention to the other things that trouble patients in terms of adherence to therapy. We need to find our patients as quickly as possible. I'm not a laboratory person, as everybody knows, but we need to find a quick diagnosis as close to point of care as possible. I'm aware of the challenges. And we need to get that information through as quickly as possible to the patients who are affected by TB. And we also need to be able to start treatment as quickly as possible. I live in Johannesburg. I have access to a vehicle, which means that I could drive to see my doctor a couple of times without really harming my household budget. But that's not true of many people who acquire TB. That a trip to the clinic is very expensive. It costs them it costs them in transport costs, a lost day of wages. So we've got to be able to start treatment as quickly as possible. For my final part of this address, I'm going to talk about how we have adopted new technologies in the field of TB and what it's taken to actually do this. The first thing is we were one of the first countries to use the GeneXpert technology to diagnose TB. It was done for two reasons. One, the fact that many of our patients are HIV co-infected, and using a smear, aside from the fact that it was a technology that was over 100 years old, it did not tell us it was a poor diagnostic tool in people with advanced HIV, probably the people who most need the intervention of rapid treatment initiation. In addition to that, we saw an increasing burden of rifampicin-resistant TB. And basically, to survive to actually getting appropriate treatment for drug-resistant TB took at least 100 days from the time of someone thinking that the person has TB to then swallowing their first medicine for the treatment of drug-resistant TB. So the GeneXpert has rapidly closed that gap by enabling us to diagnose rifampicin resistance much quicker. And what we have discovered is that many of our patients with a rifampicin-resistant TB, it's as much surprise to them as it is to us. It is a transmitted infection, and it just depends on who you happen to be unlucky enough to be sitting next to in public transport, going to school with, or working in a hospital. So the rapid detection of rifampicin resistance can now be seen to have an effect in our drug-resistant program with a decreasing incidence aside from the COVID years, because we've been able to treat people effectively sooner. We've also implemented the use of the line probe assay to detect further resistance. And obviously the most important resistance that we're concerned about is the resistance to a quinolone, because that totally changes our mind in terms of how we're going to manage the patient. And most South Africans who are diagnosed with TB are diagnosed via a GeneXpert, and most receive a line probe assay to confirm INH resistance and quinolone and second-line injectable resistance for what that's worth. The other thing that our TB program has been phenomenally flexible with is the introduction of new drugs into our program. The original registrational trials for bedaquiline were conducted in part in South Africa, and it was apparent to clinicians and to our TB directorate that this was a game changer. And even prior to it being registered within our borders, we had a bedaquiline clinical access program for patients with difficult to treat TB. That the success rate in this particular group was about 73%. And using the old definition of XDR, that was an extraordinarily high success rate. And it also paved the way for South African clinicians to start to get used to the use of bedaquiline. We dropped the use of injectables in 2018, and we now have an all-oral bedaquiline-containing regimen. And we consume more bedaquiline in South Africa than any other country. My estimates is that we have prescribed about 30,000 or maybe even 35,000 doses or courses of bedaquiline. We followed that on with a delaminate clinical access program, again, a new drug, and we afforded access to South Africans or those who live within our borders through a delaminate clinical access program, the results of which will be published quite soon. But as South Africans, we never rest on our laurels. As soon as the next trial was completed, we started looking into how to implement implement the BPAL regimen within South Africa. We started our bedaquiline clinical access program just short of a year ago. It's been conducted in 4 sites in South Africa, and we are trying to expand to as many provinces as we can. We've enrolled 80 patients, and interestingly, because South Africans do things slightly differently, about 60% of our patients are in fact fluoroquinolone sensitive. What COVID taught us is that getting people to a clinic is difficult. There were times when South Africans were really not allowed to even leave their homes. And the quicker that we can get someone treated with the fewer amount of medicines and get them back to their normal life, the better. Again, 50% of our patients are HIV co-infected, and we will soon be looking at the data as to the time to culture conversion. We've had a handful of patients that have completed treatment. I hope that this has been enlightening and some of my thoughts on how to introduce new technologies into ending TB. I think it can be done. And not only, I think it can be done, we've done it in South Africa, and we are looking forward to introducing more and more technologies to help us get rid of this disease that affects everyone from the smallest child to the oldest adult, and can cause, while it is curable, can cause long-term pulmonary dysfunction that disables our patients. Thank you very much for your time and attention.
So Francesca, thank you so much. I want to kind of point out, Sergio actually, I think, had to catch an airplane. So we're very fortunate to have Willow Brock, who's going to be filling in for him. Thank you, Sergio.
Thanks for, yeah, sorry about that, but Willow is pretty well versed, and Francesca and I come from the same university, so she'll be able to cover most of this. And thank you again, David, for having us. Willow, over to you.
And Willow is the Vice President of External Affairs at FIND, and he actually has been that director since 2021, but I think we've all known him for really many years. So this has been a fantastic set of presentations, and I kind of want to be a little bit provocative and hopefully engage all of our speakers. So I think we really just had a fantastic presentation that sort of really highlighted, in some ways, the need for early diagnosis as a way to prevent transmission. And Maria, I was really intrigued about your slide that showed the possibility of a 7 to 10 day regimen. So the thing I would love to hear you guys discuss for this first part is for this concept of asymptomatic TB and sort of enhanced case finding, which I think in conjunction with shorter treatment regimens could really be a game changer in terms of prevention of transmission. I don't have a particular order to go in, but maybe Maria, to start off with you, since you highlighted the possibility of a 7-day treatment regimen.
Well, as I said, this is our aspirational goal and our dream, and how we see our ultimate objective in the horizon. It's not that we are currently working on any kind of protocol that would evaluate such a short treatment duration, but we're working very hard in discovery, trying to imagine potential combinations that could lead to as short as possible treatments for tuberculosis.
And Willow, maybe I can ask you this to kind of carry on that way, is do you think, obviously the success in both North America and Europe in TB eradication really relied on tools that existed at the time, which was case finding, x-rays, et cetera. What are your thoughts about sort of community-wide case finding efforts to sort of try to find those asymptomatic cases and ideally prevent transmission?
Thanks, David. And I think that's a really great question. There was one in the Q&A at some point about the reliance on health systems, right? We represent here a discussion on diagnostic tools, on therapeutic tools, on preventative vaccine tools. But I think the health system that delivers this is equally important, and I think we shouldn't forget that. So one of the things which we have seen with the diagnostic development, aspects of use of gene experts is sort of, it still remains quite far away from patients. And I think Francesca is maybe one that a person that can respond to this from a health system perspective. I think what we need to do is not just go for better tools, but thinking about how do we get them close to people. And the breakthroughs we have seen in COVID over the last years, for instance, are showing us some pathways to really having more diagnostic tools that could be point of care, that could showcase a result to a patient in one session. I mean, at the moment, you often have to go 2 or 3 times to the same provider, just simply do the test and come back for a result. I think Tina would have, you know, her story is about having to come multiple times before you even know what there is, right? So I think that the diagnostic tool in a health system that can basically identify you and get you started on treatment in one session would be an enormous saving, would be cost saving and life saving for at least. So I think that health system piece is there. I think the technology is becoming available. And we've seen from the investments in COVID how that could start looking like, and even having people do self-tests, right? I mean, that's in COVID, this suddenly became possible within a year, including WHO guidelines and the whole rest of it. I think with improved technologies, that is similar to Maria's 7 days ambition, is an ambition we can have, a tool that is available almost at least at point of care, at patient level, at primary healthcare level, that can give you a test and also showcase what resistance there might be in one sitting, in one, you know, in a few hours.
Thank you. So this one, there's quite a few comments in our Q&A that really get at how can we better involve communities early on in this kind of innovation steps. And I think this is really aimed both at Tina and Robert, sort of how can we better do innovation in the context of community involvement. Tina, do you want to kick off, or?
I think Robert had unmuted. I'll let him share his thoughts first, and then I'll piggyback off that.
Okay, thank you. And I speak under Tina's control. From Unitaid's perspective, I think this is obviously absolutely critical when new innovations are being designed. Take, for example, you know, novel diagnostics or novel treatments. And upfront during the design phase, it is really important to ensure that insights from those living with TB or affected by TB are solicited and taken into consideration where there's an opportunity for that in the design phase. So it's not done, you know, too late or post facto when investments have already been committed to design a formulation or to design a test in a particular way. This is a given. Obviously, it's not unique to TB. It should be applicable to HIV, malaria, and other key epidemics. So that hasn't been done sufficiently, I would argue, in the TB space, as say has happened in the HIV space, and much more needs to be done in that regard. So I can speak from Unitaid's perspective in our new strategy, which is undergoing finalization for the next 5 years, 2022 to 2026. There'll be a massive emphasis on this dimension in one of our new strategic objectives. We are an agency that invests in innovation, usually from phase 3 onwards, right through to delivery and uptake. And that's a feature that we really want to strengthen in how we approach innovation and insights and design. Equally, on the other end of the access spectrum, it's really key to work with communities and those affected or living with TB on uptake. There's no point in eliminating all the other access barriers to new tools introduction and then stumbling at the last hurdle when it comes to policy change, uptake, health literacy, demand generation in country. And it's not enough to pay lip service to that. You have to capacitate and resource and work with communities and community networks on the ground in order to do that. And again, I expect and hope others will be doing this. The Global Fund in their new investment case, Unitaid in its new strategy, beyond advocating, we intend to put resources and financing behind this as well, because it's really key. So I'll just say that, and because that's going to be a critical enabler to the impact the new tools can have. It's not just about the technology; it's about ensuring that they're designed appropriately, and also then there's uptake and demand for them at the end of the day. Over.
Thank you.
Yeah, thanks, Robert. So I'm going to echo that. You all talked about the novel therapeutics and regimens and vaccination that we're looking to develop or developing, but without the community education piece and the want for uptake by community, there's nothing there, right? So educating communities, especially as an Asian American, I will tell you the stigma of diseases like TB is still there 20 years later. I remember when I was treated for TB, my mom telling me, do not tell anybody that you have TB, because there's just a huge stigma in the Asian American community about it. And I will say 20 years later, it's better, but it's not at a point that somebody like me would come out and say, hey, I have TB or I had TB. So, as we look at TB numbers and deaths and the amount of cases, the amount of people coming forward to say I have TB or I had TB is still low. And so the stigma is still there. And overcoming some of those stigmas and realizing that community engagement and education needs to go hand in hand with research is the piece to really just eradicating the disease. So thank you for the question, David. And thank you, Robert, for your efforts on doing that community engagement piece.
Well, thank you guys. So this one's for Lou, and you guys can probably see there are a lot of questions about sort of surrogates and how we might make progress. There's some very thoughtful comments. So Lou, I'm going to ask something sort of practical and then something kind of provocative for you, and that I think will kick us off into what I'm hoping will be sort of a thought-provoking conversation about funding. So Lou, my first question is, you kind of mentioned the need for correlates of protection. And my question is sort of, how do we get there? And do you think there's only one correlate?
How do we get there? We get there by having a successful vaccine. That's the reality. That's the challenge. The first vaccine that breaks through, when we get a successful vaccine, then success being defined as efficacious at, in this case, let's say preventing disease. If we make the investment, the appropriate and necessary investment, not only to assess efficacy, but to make sure that we bank the amount of the kind of specimens that we need, so that if efficacy is then identified, we can go back and do the experiments that are needed to actually identify an immune correlate. Then we have a target. Then we have a map for the next generation of vaccine developers to follow as they develop their new vaccines. They're not just flying blind, and that would be such an extraordinary help to the entire field. Do I think there's one correlate? I can't believe you're asking it. You should be answering that question, not me. But I will take a shot at it, and then you can fill in. I think probably not. I think that there are a number of different immune responses that are going to be necessary, and maybe it's I think maybe the M72SA01E vaccine is teaching us that. We have a couple of proteins, out of 4,000 plus on MTB, right? So you have a couple of proteins with an adjuvant, and yet you see, at least in the phase 2B, 50% efficacy. Now that's already a good sign, and in there may be a correlate, but what does that do with the other? What does that mean for the other, thousands of antigens of which a select number will be truly immunogenic and important in their immunogenicity? There are probably going to be a number of different correlates. We just have to identify them and then utilize them to develop the next generation of TB vaccines.
Thank you. No, I'm not going to answer your question about correlates. But I want to sort of end on something a little bit provocative. I think you all mentioned sort of the revolution that we've seen as a result of kind of, I think, this real sense of danger and urgency, and as a result, funding that went into COVID. And it really truly has been a revolution. And then I look at the vaccine space, and I think we had a very nice comment both about sort of the relative paucity of candidates, especially upstream. And I have to say that, you know, those antigens that Lou mentions that are to M72, I was on the team that did those, and we published that in the late 90s. And then we have phase 2B studies that come out in the late, 2018, 19, and we have yet to start a phase 3 study. And I find that unacceptable. And so when you look at the funding for COVID, what's really remarkable to me is that it's largely sort of public-private partnerships that have really enabled that. So my question for all of you is what are the barriers for us in thinking about really enabling these public-private partnerships? What is slowing us down? I think we all know that it's money, but how do we really either create that sense of urgency, or how do we entice corporations to really be excited about TB? And I'm gonna maybe I'll hand this over. Any of you guys think could jump on that? Maybe I'll start with Willow, and there's only a few minutes left, so if you could just leave us with a few comments, and I'll try to get to everybody.
Okay, thanks, David. Just a simple question to end, I would say that one of the things that will make a difference, at least in diagnostics, is where, and this was again in some of the Q&A moments, we see multiplex testing, point of care molecular coming out. If, like we currently have today, if these are really bifurcated program by program, so only available for TB, it's going to be a problem to make that technology available for everyone. If the health systems buys these new diagnostic tools to be able to identify TB, HIV, malaria, diabetes, non-communicable diseases, which in basically these technologies can, you open up a much more significant market. And the reason why COVID was so popular, because it was a market of 7 billion people. If we can have some of these new technologies that are available become available at that scale, industry will, in my view, be much more interested than currently when you're catering to 1 million people globally. So let me stop there and hand over to the others.
Great. Actually, maybe Maria, how about a comment from you?
Yes, well, I have to say I agree with what Willow just said. I mean, increasing sensitization to the reality of tuberculosis and the number of patients that die daily. Sometimes people are unaware, and in certain circumstances, people are not really understanding the gravity of the TB pandemic that kills so many people in countries that probably are also hampered by poverty and many more difficulties that we see in the more developed world. So for me, what we can do is continue to make progress, and this will motivate actually investors or donors to contribute to our research. Sensitization, education, I guess it's for me the key element.
Thank you. And Robert?
Thanks, David. I'll be brief. It's a challenging question to end with, but I know that's why you did it. I fully echo what Willow has said, but what that implies is that up to now, the moral, economic, and public health case for TB has not been sufficient. And moving forward, the cynic in me would say it won't be. So the case we have to make has to be different. On the one hand, I would argue, therefore, that we have to do a better job around the economic investment case of investing in novel tools and capacities for TB prevention, treatment, and diagnosis. Tens of millions of dollars are invested in ODA and other development initiatives, but when the health of millions of people is compromised because of that, unless we articulate to development funding partners, multilaterals, bilaterals, and otherwise, the sort of economic dimension of addressing this disease more articulately, then we're not going to get where we need to get. So that's one aspect. The second is, we've tried this before to demonstrate that TB as an airborne bacterial illness does have potential risk down the line to mutate, develop more complex variants that could be a threat beyond low and middle income countries and some UMICs. I'm not sure if that case could be made more cogently moving forward and credibly. But again, unless we appeal to self-interest rather than people's moral compass, I don't think we're going to get as far as we need to get. So a bit more of a cynical response, but that's what our history has taught us. And so we have to find smarter ways to articulate for the investments here. Over.
Thank you. And if the organizers will humor us, I'd love to have a few comments from Francesca and then let Tina kind of have the final word.
Thanks. So if we think of what a national TB program is facing, they're facing people who are presenting very unwell. They need to deliver services to them as much as possible. And I think that what we need to do is to demonstrate that we as researchers are in it for the long game, that we are committed to assisting not necessarily with service delivery, but making the job of NTPs a little bit easier. So shortening regimens, things like the diagnosis of bedaquiline resistance, that needs to be forefront. I'm not interested in second-line injectable in resistance anymore. So what we need to do is to show that we're not here for our own academic pursuits. We're not here to improve our CVs. We're here to improve care given to people who are either infected with TB or potentially infected with TB. And I hope that's not too much of a cynical response as well. Thank you.
Okay, thank you. And Tina.
I will say, I think the power of the voice of survivors and those who are currently in treatment can't go without, there's just a huge power to it. And I think, I will say, when I tell people that I had TB, they're like, I thought there was a vaccine for that. I thought that was eradicated. So the power of being able to say, I had TB or I have TB. We Are TB works with people to provide that support and the courage to be able to speak out and say, this is not okay. It can happen to anybody. And it's time to really, eradicate the disease. It's been too long and it's time. So I hope that my voice and the voices of We Are TB, as well as other advocacy networks throughout the world, are able to help move the needle to get the funding that TB really deserves to help eradicate the disease.
Thank you. So I'm sure we're supposed to wrap. I first of all wanted to thank our panelists for really, really fantastic talks. And we know that this is going to be another very exciting year in TB, I think highlighted by another UN high-level meeting that will take place in this next year. And I hope we can all be a little bit inspired to sort of take our cue both from COVID and also from the HIV of the past and saying, how can we raise the sense of urgency that I think we desperately need for TB to sort of both garner funding, but I think garner the will to really tackle a problem for which I think you all highlighted the science is fantastic. So we're really seeing that the science really supports TB diagnostics, short course regimens, vaccines. So it's really, the time is really now to really inspire, I think, us and the world to really eradicate TB. So with that, I'm looking at our organizers, but I think it's probably time to sign off. And again, thank you guys so much.
Thank you, everybody.
Thank you.
Thanks
very much.
Great meeting. Thank you.
Thanks, everyone. Bye-bye.
Bye, everybody.
Thank you.